Hello everyone, my name is Purya and today I will be talking to you guys about a data analysis research project on Hodgkin lymphoma done with the Curate Lab at BC Cancer Research Institute. I'll be talking and going over on an overview of the disease, the role of imaging, and what the patient data actually shows. So a quick walkthrough of the presentation is grouped into three chunks. First, I will be going through the background on lymphoma and nuclear medicine, then the data set and key variables, and lastly, I will be talking about the actual analysis and Kaplan-Meier results. So I'll start with some background on what Hodgkin lymphoma actually is. Lymphoma is the cancer of lymphatic system and it splits into two big families, Hodgkin lymphoma and non-Hodgkin lymphoma. And Hodgkin lymphoma is the much rarer of the two, encompasses about only 10% of all lymphomas. Now, Hodgkin lymphoma, the defining diagnostic feature of it is the presence of Reed-Sternberg cells. As you can see in the image here, this whole thing is actually one cell, the Reed-Sternberg cell, despite having three nuclei compared to the normal lymphocyte right next to it. It looks like an owl eye, you can say. So these are abnormal giant multinucleated B cells, and they start out in the lymph nodes in the chest, neck, and the underarm region, and spread in a predictable manner from lymph node to lymph node group, unlike many other cancers. And they are highly treatable. And also, Hodgkin lymphoma has two different subtypes: classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Now, classical Hodgkin lymphoma is the most common one, the most dominant form of all. Encompasses about 95% of all cases. And it has four histological subtypes. The first one is the nodular sclerosis, and it's named for its appearance under the microscope. It's characterized by the Reed-Sternberg cells and the bands of hardened scar tissue that divide the affected lymph node into distinct nodules. The next subtype is mixed cellularity, which is a mix is characterized by a mix of Reed-Sternberg cells and lymphocytes in equal pattern. Next one is lymphocyte-rich subtype, which is non-aggressive. It's characterized by the presence of very few Reed-Sternberg cells surrounded by very many lymphocytes. Lastly, the lymphocyte depleted subtype, which is the rarest and the most aggressive subtype. It's characterized by the presence of many Reed-Sternberg cells surrounded by very few lymphocytes around it. Now, the marker profile for classical Hodgkin lymphoma is the presence of CD30 and CD15 B cell markers and the absence of CD45 and CD20 B cell markers, both cases together. Next is the nodular lymphocyte predominant Hodgkin lymphoma subtype. It is much rarer as it encompasses only 5% of all cases. It is a slow-growing lymphoma and contains lymphocyte predominant cells, or so-called popcorn cells, because of their appearance under the microscope. As you can see in the image here, in figure A and B, as you can see these four cells here look like a popcorn, or in figure B it's much clearer. They actually do look like popcorn. Now, the marker profile, how we can identify nodular lymphocyte predominant Hodgkin lymphoma, it's by the presence of CD20, CD45, CD79A, PAX5, and BCL6 B cell markers, and the absence of CD15 and CD30 B cell markers. Pretty much the exact opposite of classical Hodgkin lymphoma's marker profile. Now, what are the symptoms of Hodgkin lymphoma? The most common symptom of Hodgkin lymphoma is called B symptoms. It's a group of three symptoms that include drenching night sweats, unexplained recurring severe fevers, and severe weight loss of about 10% of initial weight loss in about 6 months. Other symptoms include painless swollen lymph nodes, itching, fatigue, cough, or chest pressure if the chest nodes are enlarged, and in very rare cases, pain in the lymph nodes after alcohol consumption. How do we diagnose Hodgkin lymphoma? Well, routinely, a lymph node biopsy is done, and excisional lymph node biopsy is preferred over a needle sample because the architecture matters for diagnosis. In the diagram here, the lymph node biopsy done is on the cervical nodal mass. Blood testing, specifically flow cytometry, is done to diagnose Hodgkin lymphoma. CT and PET scanning is done to determine staging, and rarely, and it's not routine anymore, bone marrow biopsy may also be needed. How is Hodgkin lymphoma treated? Well, chemotherapy, specifically the ABVD regimen, is the frontline standard treatment of Hodgkin lymphoma all around the world. Now, the ABVD regimen, abbreviated for the first letter of the four drugs used in chemotherapy. The four drugs include adriamycin, bleomycin, vinblastine, and dacarbazine drugs. Hodgkin lymphoma can also be treated through radiation therapy, involves site or involved field, and it's used in early stages and or for extra local control. In the diagram here, you can see radiation therapy is used for breast cancer. Now, the advantage of radiation therapy is that it only affects the cancer's tumor, of course, and very little healthy tissues around the tumor. Unlike chemotherapy, in chemotherapy, the drugs affect the cancer's tumor and all the healthy cells in the body, which is uh, pretty bad. Immunotherapy is also done for advanced cases, and if relapse occurs, stem cell transplant is also going to be done. How is stem cell transplant done? Well, if relapse occurs, stem cells are exported or taken out of the bone marrow. Very heavy and aggressive doses of chemotherapy are done. Once all the cancerous cells are eradicated in the body and from the bone marrow, then the bone marrow is revived by injecting and putting all those stem cells back into it. Now, what are the causes of Hodgkin lymphoma? The most common one is the Epstein-Barr virus. Now, EBV itself doesn't directly cause Hodgkin lymphoma in most people. Instead, it increases the risk by infecting B cells and making them survive a lot longer when they should normally die. So it lengthens their lifespan. And of course, over time, this contributes to the accumulation of additional mutations that could lead to lymphoma. Other causes include weak immune system and also family history. Now, Hodgkin lymphoma is also mostly seen in people ages between 15 to 35, so young adults, and also people aged above 55 years, so older adults. Now I'll talk about the imaging slide, specifically nuclear medicine, since this is central to how Hodgkin lymphoma is staged and monitored. Now, nuclear medicine uses radioactive tracers to image function and metabolism, not just anatomy like a regular CT. FDG, fluorodeoxyglucose, which I'll talk about in the next slide, is a glucose molecule with one oxygen atom, the OH group, swapped out for a radioactive fluorine 18 atom. It's injected into the patient's bloodstream. Now, cells take up FDG the same way they would take up normal glucose through their glucose transporters. But once inside the cell, FDG gets trapped because it cannot complete the normal glycolysis pathway past a certain point. So it accumulates in metabolically active cells. Now, cancer cells, as we know, are just unusually hungry. They take up far more FDG than most normal tissue cells would, and it makes them light up on a PET scan. Now, how does it make them light up? The fluorine 18 atom is unstable and it decays by emitting a positron, which is a positively charged electron. The positron immediately collides with nearby electrons, and the two destroy each other and produce two gamma ray photons that fly off in exactly opposite directions. The PET scanner now has a ring of detectors around it, around the patient, that catch these paired photons and uses their timing and geometry to create a precise 3D map of where the radioactivity is coming from in the body. Now, PET scanning alone gives great functional and metabolic information, but has very poor anatomical detail, as you can see in the image here. The anatomical detail here is just very blurry. It's not good. So it's essentially always paired with a CT scan imaging done in the same machine in the same session. the same time. The CT scan gives very sharp anatomical detail. As you can see here, the anatomy of it is pretty good. However, there's no functional information. So the two images are digitally fused together so that the doctors can exactly see where the hot spot in the body is and where the metabolic activity is at its highest. Now, I'm going to just quickly talk about the difference between FDG and glucose. So on the left, we have fluorodeoxyglucose, and on the right, we have regular glucose. The major difference between FDG and regular glucose is on their second carbon here. In regular glucose, an OH group is connected to the second carbon. However, in FDG, instead of an OH group connected, a fluorine 18 atom is connected to the second carbon. This is just a major difference between both. It also causes structural differences, but the OH and the fluorine 18 being connected to the second carbon is the major difference between both of them. Now, how is Hodgkin lymphoma monitored? It's monitored through 4 stages. The first one is called initial staging. So after biopsy confirms Hodgkin lymphoma, a baseline PET CT scan maps out every cell of the disease in the body, so lymph node regions and any other organs involved, which determines the cancer stage through 1 to 4. Now, PET scan is actually more meaningfully sensitive than CT alone for detecting lymph nodes and bone marrow involvement. Next step, we have the interim or mid-treatment response assessment. Now, a PET scanning is done partway through chemo after about 2 cycles, and it tells doctors in real time whether the treatment is working or not. And this is actually our PET med column in our data. Now, this right here is nuclear medicine's biggest contribution to modern Hodgkin lymphoma because it enables response adaptive therapy. What is that? Well, patients whose interim scan is clean may have the treatment intensity reduced to spare them from unnecessary toxicity, while patients who still have active disease or the scan shows active disease, their regimen, their treatment will be switched to a more intensive, more aggressive one before they go through the whole treatment. Next one is the end of treatment response assessment, and it's our PET end column in our data. This scan determines whether a patient achieved a complete metabolic response, or they've been cured, you can say, or still have residual or active disease in their body. Now, it's very huge because it directly answers a question that the CT scan alone can't answer by itself. If there's still a lump or mass visible on the CT scan after a chemo, we're not going to know if it's active cancer or it's just a dead scar tissue left behind, right? Now, here's where PET scanning is very useful, right? Because once FDG is injected into the body, the active cancer will very aggressively take in the FDG. However, the dead scar tissue left behind, it's dead, and no FDG will be taken in by it. That's where PET scanning shows us if there's an active disease or the cancer is still in there, or it's just scar tissue. Now, before PET was routinely used, doctors would sometimes have to do biopsy to figure this problem out. Lastly, it's detecting relapse. In follow-up, PET CT can detect a recurrence of the disease sometimes before it actually becomes very obvious and aggressive. Now, walk through the actual data set work with 616 Hodgkin lymphoma patients from BC Cancer. So the mean age at diagnosis was 38.4, and the youngest patients he was 17 years old, and the oldest patient was 69 years old. The middle 50% of patients, so the 25th to 75th percentile, fell between about 26 and 51 years old, which is consistent with Hodgkin lymphoma's known bimodal age distribution of young adults and older adults. There were 335 male patients, up 54.4%, and 281 female patients, about 45, almost 46 percent of all 616 patients were female, which is a modest male predominance, consistent with Hodgkin lymphoma's epidemiology, which is, Hodgkin lymphoma is slightly more common in males. Now, age distribution by sex. This is a stacked histogram. It buckets patients into age bands colored by sex. The male patients are colored blue, and female patients are colored pink. The data clusters very heavily in the 20 to 30 age range, and then another meaningful presence in the 45, about here, 45 to 60 age range. And it's a visual hint at Hodgkin lymphoma's bimodal age distribution I just talked about, of infecting young adults and older adults. Now, this diagram it's a very great diagram because it connects a known biological fact about Hodgkin lymphoma directly to a pattern found in real patient data. Ann Arbor staging system, which was later refined by the Lugano classification that incorporates PET findings. It describes how far lymphoma has spread using a number of 1 to 4 plus a letter A or B and sometimes additional modifiers. In our case, it's the letter E, which I'll talk about. Now, stage 1 means the involvement of a single lymph node region or a single extranodal site, as you can see. Just one site anywhere in the body is involved. Stage 2 is the involvement of 2 or more lymph node regions on only one side, the same side of the diaphragm. So all above or all below. So now you see this dotted line here is the diaphragm. In stage 2, all the involved sites are on the same side, only on one side of the diaphragm only. So in this case, uh, all the involved sites are on above the diaphragm. Stage 3 is the involvement of lymph node regions on both sides of the diaphragm, so both above the diaphragm and below the diaphragm. Stage 4 is the involvement of one or more extra lymphatic organs, so organs in the lymphatic system. It's important. Organs only in the lymphatic system, beyond what's just adjacent to an involved node. Extra lymphatic organs include liver, bone marrow, lungs, blood, small intestine, etc. Now, as I mentioned, there are also letters. Letter A would indicate absence of B symptoms, drenching night sweats, severe fevers, weight loss of more than 10% of initial weight in 6 months. B is the presence of B symptoms, and E denotes extranodal extension, basically metastasis, and that disease has spread from a lymph node directly into an adjacent organ outside of the lymphatic system, irrelevant of the lymphatic system. So this is the diagram of stage at diagnosis. The two dominant groups are 141 patients and stage 4B and 138 patients at stage 2B. Now, this cohort skews towards advanced stage B symptom positive disease. Likely it reflects a high risk or referral population rather than a general community sample. ECOG performance status. What is that? Well, performance status assesses how a disease like cancer impacts a patient's daily living abilities, prognosis, and eligibility for treatments. Now, it matters a lot in real practice because performance status is one of the strongest predictors of how well a patient will tolerate aggressive chemotherapy, and it factors directly into treatment decisions, right? Now, let's go through the definition of what each of the scores mean. For example, a PS score of 0 means the patient is fully active. Score of 1 means the patient is only restricted in strenuous activities. Score of 2 means they can only do their self-care activities, and they're up and about outside of the bed more than 50% of their waking hours. Score of 3 means they can only perform limited self-care activities, and they're up and about outside of the bed less than 50% of their waking hours. And a score of 4 means that the patient is fully disabled. Now, as I said, the scores are very important in the course of treatment and decisions, because physician may choose a gentler regimen for a patient who has a score of 3 or 4, even if a more aggressive one would be more effective, theoretically, right? because the patient may not even survive the toxicity of the more aggressive option because of uh, how restricted they are in their activities. Now, going through the stats of our own data, more than 50% of our patients were only restricted in their strenuous activities. 120 patients had a score of 2, and 102 patients were fully active. 38 patients achieved a score of 3, and 10 patients out of 616 patients were fully disabled. Now, just visually reinforcing on what I've already said, score of 1, PS1 dominates, and then there's small numbers at PS3 and PS4, about, I think, 38 for both scores of 3 and 4. Now, the outcome status of our patients. So, out of 616 patients, 456 patients are still alive, about 74% of all patients. 120 patients were announced dead, about 19.5%, and 40 were lost to follow-up, 6.5%. The average survival time of the patients was about 8.7 years, and the freedom from treatment failure time, the time it takes since diagnosis until a treatment has failed, is about 7.3 years. And these are raw averages of the follow-up time, not the formal Kaplan-Meier estimates that you'll see me talk about later. Now, before I get into actual outcome analysis, I want to define two variables that come up a lot uh, in oncology: the Deauville score and staging. Now, I've already talked about staging a lot. I'm not going to go over it. I'm just going to talk about Deauville score. Deauville score is a visual 5-point scale used to interpret how metabolically active a site of disease looks on a PET scan by comparing its FDG uptake to two internal reference points in the patient's own body: the mediastinal blood pool, which is the background activity in the big blood vessels of the chest, and the liver, which has moderate to high, fairly uniform uptake. Now, if you use the patient's own tissues as reference points rather than an absolute number, it allows the scale to be more consistent across different scans, machines, and patients. Now, scores of 1 to 3 are considered negative scores, and they're considered complete responses, successful treatments. And a score of 4 or 5 is considered a positive score, positive response. It means there's still residual activity, a possible treatment failure, the cancer is back, metastasis has occurred, or tissue healing and infection is happening. Now, as I mentioned, the site of cancer is compared to two reference points in the patient's own body: the mediastinal blood pool, which has low brightness, as low activity, which is the lower baseline, and the liver, which has high brightness because it absorbs high steady amounts of sugar. It serves as the uh, higher baseline. Now, getting to the what all the numbers mean. Score of 1 means that there is no FDG uptake, so it's the cleanest score. There's no more cancer left in the body whatsoever. Score of 2 means that the FDG uptake is less than or equal to the mediastinum. Score of 3 means that the FDG uptake is more than the mediastinum, but it's less than or equal to the liver. So these are the clean scores. This means that there's no more cancer left in the body. Has been cured, basically. Now, score 4 means that the FDG uptake is more than the liver at any site. And score of 5 means that the FDG uptake is more than the liver at any site, and there have been new sites of the disease observed in the scan. These are the scores of 4 and 5 mean that there's possible treatment failure or metastasis. Now, talking about primary endpoints, in cancer research, an endpoint is the specific outcome the study measures to determine whether a treatment worked or not. Now, choosing the right endpoint is a very important decision in clinical trials because different endpoints answer different questions. First endpoint is overall survival or OS. Now, overall survival is considered the gold standard endpoint in oncology because it is completely unambiguous. There's no room for interpretation about whether the event happened or not. And it directly answers the question that everyone cares about the most. Did the treatment help people live longer or not? But there are two major downsides to it. It can take a very long time for to observe enough deaths to draw meaningful conclusions, especially in a highly curable cancer like Hodgkin lymphoma, where most patients actually get cured and tend to live and survive for decades. The other downside with it is that it's contaminated by deaths that have nothing to do with the cancer or its treatment, such as car accident or cardiac disease unrelated to the lymphoma. The next endpoint is called the freedom from treatment failure, FFTF. The time from diagnosis or treatment start until a treatment failure event is called freedom from treatment failure, which is a broader, earlier occurring category than just death alone. It typically includes disease progression during treatment, relapse after achieving remission, or death from any cause. Now, the major advantage with it is that because relapse or progression events generally happen much sooner than death does, FFTF type endpoints let researchers get a meaningful conclusion of whether a treatment is working years before an overall survival analysis would have enough deaths to be meaningful. Now, this is why nearly every modern Hodgkin lymphoma trial reports something in this family, an FFTF family endpoint. And it's also important to report both endpoints side by side than one of them alone only, because together they tell us a richer story. For example, if FFTF looks great, but overall survival doesn't improve as much, well, then it suggests that patients are relapsing less often, but then they're dying of something else, like treatment toxicity, at a similar rate. This is exactly the kind of nuance visible in our cause of death column, where there's a meaningful share of deaths from secondary cancers or heart disease rather than just lymphoma progression itself. Now, in our data set, both endpoints are structured as time to event data with a binary event indicator of 0 or 1, plus a time value in years. And this structure exists because of a concept called censoring. Not every patient in the study experiences the event of interest before the study or the follow-up ends. A patient who's still alive at last follow-up or who was lost to follow-up hasn't had the event yet, or we just simply don't know if they will or when they will. So their event indicator is going to be 0, but the recorded time still counts as valid information because it tells us this patient has survived without an event for at least this many years. This censoring concept is the whole reason why Kaplan-Meier analysis exists, which we'll soon talk about very soon. Now, I've gone over this once, this stage distribution and diagnosis. It's just more detailed. The two dominant groups are 2B and 4B with about almost 300 patients. Now, Kaplan-Meier plot, which I promised to talk about to all of you. Now, Kaplan-Meier plot is a non-parametric stat used in survival analysis to calculate the probability of a specific event, like death, relapse, or device failure, occurring over a given time period. It's highly valued for its ability to handle censored data, cases where, as I mentioned, subjects drop out or they're lost to follow-up or the study has ended before the event occurs for them. The x-axis is the time since diagnosis, and the y-axis is the survival rate, 1 being 100% survival probability and 0 being 0% survival probability. Now, talking about slopes, a steep drop indicates a high rate of the event occurring. So poor survival, that means a lot of deaths are occurring if there's a steep slope. While a flatter curve means there's a higher survival rate, means there's stability. Now, I mentioned that Kaplan-Meier plot handles sensor data very well. Well, how does it do that? The tick marks or the small vertical lines here, as you can see I'm pointing to, along the curve denote censored patients. Now, I'm going to get into Kaplan-Meier plots for our own data and explain why it is such a good tool to handle sensor data. And I explain the whole thing in much more detail. Now, imagine we wanted to just calculate the average survival time for all of our 616 patients. We would hit a big obstacle. 456 patients are still alive. About 75% of our patients are still alive. And we don't know their eventual survival time. We only know they have survived for at least however many years since diagnosis so far. If we exclude these patients from the average, because we don't have the final number, of course, we would be throwing out 75% most of our data and would bias the results toward only the patients who happen to die early. It's very bad. If we instead treat the current follow-up time as their final survival time, then we're badly underestimating how long they've actually survived, they're going to survive. Now, this is the exact problem that censoring creates, I talked about, and it's the whole reason why the Kaplan-Meier estimator was invaded. This tool lets us use every single patient's data, including the censored ones, without throwing anything away or biasing the results. Now, the curve only steps downward is only a declining curve at event times. It's flat everywhere else. The small vertical ticks that I mentioned in that last slide, they denote the sensor events, where the patient, of course, stopped contributing and moved out of the risk set without having the event at all. Now, the shaded band around here is the 95% confidence interval, and it gets wider and wider towards the right side of the plot because fewer patients remain at risk that far out. The median survival time is the time point where the curve crosses zero point 0.5 on the y-axis or the 50%. Now, in all of our curves, it actually never drops below 50%, so the median is never reached, which for a cancer curve in oncology, it's actually a really good thing. It's a really good sign. It means that more than half of the cohort is still doing well, even at maximum follow-up time of 17 years in our case. Now, for this Kaplan-Meier plot alone, about 86.7% probability of being alive at 5 years and about 80.2% probability of being alive at 10 years exists for the patients. The plot has a gradual steady decline rather than a sharp early drop, which is consistent with a highly curable cancer up front. Also, the slow tail here towards the end reflects late deaths that, like, some of them are lymphoma related, some from unrelated causes or treatment effects. Lastly, the last Kaplan-Meier plot is the freedom from treatment failure Kaplan-Meier curve. About 74.3% at 5 years and about 72.3% at 10 years chance of failing treatment and being free from treatment failure at 5 years and 10 years. The curve drops fairly quickly in the first 2 to 3 years, then just flattens out. It means that most relapses happen very early on, and the risk drops off substantially the further out the patient gets in time. Now, this curve sits below, it's about a little underneath the overall survival curve, and it means the reason why is because every relapse counts here, even if the patient doesn't die, since many relapse patients get salvaged successfully. Now, for the plot of freedom from treatment failure and the Deauville score, I used the end of treatment Deauville review column in our data, and I restricted it only to 225 patients who had a clean, unambiguous D1 to D5 score. There were some missing annotations and loss to follow-up scores, which didn't contribute. Now, this is a plot of patients' freedom from treatment failure in years, grouped by their Deauville score with individual patient points scattered on top, spread out. Now, the negative scores 1 to 3, are in the green region on the left, and the positive scores, scores 4 and 5, are in the red region on the right. And the median freedom from treatment failure for a score of 1 is about 10.6 years. For a score of 2 is 8.1 years. Score of 3 is 7.4 years. Score of 4 is 6.5, and a score of 5 is 0.7. Just a substantial drop. Now, there's a clear step down in how long the patients stay free of treatment failure as the score rises. Patients with a clean D1 score at the end of treatment stay treatment failure free for well over 10 years, 10.6 to be precise, while the patients with a D5 scan are only free from treatment failure for 8 to 9 months. So there's a clear big drop from more than 10 years to just less than a year. Now, if you look at the score of 4, it just sits in between. Some of these patients do quite well, some of them do not so well, do really bad, but on average, score of 4 does worse than scores 1 to 3. Also, scores 2 and 3 look reasonably similar to each other and meaningfully better than D4 and D5 together. And it supports this clinical meaning convention of grouping scores 1 and 3 together as negative responses rather than treating every single point on the 5-point scale as equally distinct. Now, the real clinical action is the score of 3 versus the score of 4 boundary, not evenly spread across all 5 points. And actually shows it here. Now, one thing that has to be mentioned, must be mentioned here, is that the D3 group only has 11 patients, so its numbers are much less statistically stable than D1 with 136 patients. It means has much less patients than others. The meaning could be much noisier and more random. Well, thank you very, very much for listening. This is the end of the presentation about Hodgkin lymphoma. Thank you.